Hello, and welcome to ID Talk, Answers from Infectious Disease Experts. I am Dr. Scott Olson, a pediatric infectious diseases specialist at Banner University Medical Center in Tucson and associate professor of pediatrics at the University of Arizona College of Medicine. Along with Dr. Nathan Price, I am the Arizona AAP Infectious Disease and Immunization Co-Medical Director. And if you're looking at the thumbnail of the podcast, Dr. Price is the handsome young man on the right, and I'm the one on the left. This podcast has been created to answer questions from our chapter members about anything and everything infectious disease and immunization related. Thanks for tuning in today. This is the week of September 22nd, 2025. Let's go ahead and jump right into the questions. Question 1 comes from a reader who asks, in what ways can we improve antimicrobial stewardship as a team across outpatient and inpatient care? And how do we see it impacting pediatrics in the next 5 to 10 years? And before we get into the specifics of antimicrobial stewardship programs, I think it's important to take a second and remember why antimicrobial stewardship, or ASP, programs are so important. Well, we know that our overprescribing practices in medicine, and in particular overprescription of broad antibiotics, can drive resistance both within our individual patients but also across the greater community. The CDC has been following the threat of antibiotic resistance closely over the last several decades, and in 2019 they put out one of their most recent iterations of the Antibiotic Resistance Threat Report. And at that point, they estimated that there were over 2.8 million resistant infections and over 35,000 deaths annually in the United States alone from resistant organisms. And this is in particular concerning because while we have known for a long time that resistant organisms are a concern, the risk has been rising. So if you compare that to the overall numbers from 2012, at that point the CDC was saying that there were an estimated 2 million infections and 20,000 deaths annually in the United States from resistant organisms. So we have been still seeing increasing rates of both infections and deaths from these organisms over the last decade. And in these resistance threat reports, the CDC also highlights the ways in which clinicians and the healthcare community in general can address resistance to minimize the emergence of new organisms. And they break it down into 4 main actions. The first being preventing infection and spread, second being tracking of resistance, third being improving antibiotic prescriptions and stewardship, and fourth being the development of new drugs and diagnostic tests. Unfortunately, when it comes to that fourth point of the development of new antibiotics, the pipeline for pharmaceutical development of new antimicrobial agents is unfortunately not great. And as of now, there is only one novel class of antibiotics being evaluated called lasso antibiotics, with lariacidin being the first drug within this class being developed. Now, it appears these antibiotics work on the ribosomal subunit, but unfortunately, otherwise there are no new classes of antibiotics that are effective against gram-negative organisms, which is where we see the majority of drug resistance emerging since 1968. And most new antibiotics in the pipeline are either analogs of older medications, such as new cephalosporins, or combinations of existing drugs, such as cephalosporins plus novel beta-lactamase inhibitor combinations. So in this current environment with increasing numbers of resistant infections and very few antibiotics in the pipeline, it's important that we as clinicians think of that third bullet point of how to prevent resistance, and that comes down to improving antibiotic prescribing practices. On the inpatient side, most larger hospitals or systems have inpatient antimicrobial stewardship programs as mandated by CMS as a condition to receive Medicare and Medicaid payments. But how these systems work varies pretty broadly across different systems. But usually there's a collaboration between a clinician such as an infectious disease doc and pharmacy personnel to review in real time antimicrobial prescribing practices. How much control over prescribing practices the ASPs have depends on what sort of authority they've been given within that system. So, for example, in some areas, the antimicrobial stewardship program will have restricted antibiotics that need approval before use, whereas in other systems, the ASP simply provides real-time feedback to clinicians. We in the infectious disease field have recognized the importance of antimicrobial stewardship for some time, and there's actually an IDSA stewardship guideline that exists that's a wonderful reference. Unfortunately, this guideline only addresses inpatient systems, and so finding great guidance on outpatient stewardship programs is a little more difficult. But trying to tackle antimicrobial stewardship on an outpatient basis is certainly an important undertaking because we know that most antibiotics are prescribed on an outpatient basis in the United States. So, for example, we know that 1 in 5 pediatric visits results in an antibiotic prescription, and that's about nearly 50 million antibiotic prescriptions in the U.S. alone annually. Studies have also shown that on average, at least half of these antibiotic prescriptions are considered inappropriate. For example, acute respiratory tract infections account for over 2/3 of these antibiotic prescriptions in children, and studies have suggested that of these prescriptions, at least 1/3 of them are considered unnecessary because they are more likely the result of a viral illness. Developing outpatient stewardship programs is difficult, though, because these practices would need to apply across a variety of different clinical settings, such as an outpatient pediatric clinic, urgent care, specialty practices, the emergency department, or retail clinics. Additionally, while inpatient systems can identify an antimicrobial stewardship champion to spearhead initiatives within the system, oftentimes outpatient stewardship does require pretty heavy commitment from a local champion who's willing to lead interventions within the clinic space. However, finding time and financial support for these individuals can be difficult. Thankfully, there are antimicrobial stewardship approaches that have been evaluated on an outpatient basis and do appear to offer some benefit. So while the data is not quite as robust as inpatient interventions, there are some approaches that I think would be worthwhile considering in your clinic space. So, for example, one option is clinical decision support, where there is an individual within the clinic space who is considered the subject matter expert who can help other clinicians with antibiotic prescribing questions. Second, you could provide clinician or patient education on when antibiotics are appropriate or not, with focus on the highest yield diagnoses such as acute respiratory tract infections, management of sore throat, or when treatment of otitis media is considered appropriate. Some clinics have looked at using audit and feedback approaches to their antibiotic prescribing. However, this has been looked at in studies, and unfortunately, when audit and feedback is discontinued, some groups have seen their prescribing practices revert to the norm. Fourth, some clinics or clinic systems have instituted systemic follow-up of not only positive results but also negative results so that any antibiotic prescriptions provided can be discontinued with negative cultures. And the final approach to highlight is communication training for physicians regarding when antibiotics are needed, because I think we've all been in that circumstance where families are insisting on antibiotics for something like a sore throat, and improved communication has been shown to decrease the number of antibiotic prescriptions provided. And to come back to the last part of the original question, the member asked about how I see these practices changing in the next 5 to 10 years. Well, this is a little bit of a harder question, but I think really our benefit is going to come from automation and improved algorithms within our electronic medical records with possible inclusion of AI assistance. Now, I'm not a huge AI proponent, but I do think that it could act as a tool for certain things like screening labs or culture results, and then offering guidance on the recommended first-line therapy in that context. It will be interesting to see where antimicrobial stewardship and antibiotic resistance goes in the next 10 years, because as I mentioned at the beginning of this question, we're not doing a very good job of controlling it currently. So I think just my last message to all the providers out there is, when you are seeing a patient, really only prescribe antibiotics if you're sure it's a bacterial infection. Use the agent that is the most narrow and targeted as possible, and make sure you're not using it for too long of a duration, because remember, we know that overuse in terms of using antibiotics too long is also associated with resistance. So keep that in mind as you're seeing those patients, and we can all work together to try to minimize the threat of resistance in our community. Moving on to question 2, a member asked, Have you seen any increase in post-COVID symptoms or long COVID presentations in children? Now, I have a presumed answer to this question, but I admit I had to go do some digging to get the actual numbers, and thankfully, they seem to have confirmed my suspicion. Before I start, I'd like to explain a little terminology just so I don't confuse people as I go on. I'm going to be referring to post-COVID symptoms as post-COVID conditions, or PCC, and long COVID falls into this category. And I'm going to use that terminology because a lot of studies are looking more at persistence of symptoms after acute illness as opposed to necessarily describing all conditions as long COVID. Now, as the pandemic has progressed, we know that there are certain factors associated with an increased risk of developing PCC, such as hospitalization or ICU admission with the primary infection, infection in women, infection in those with underlying conditions and those older than 65 years, and infection in those who are unimmunized. Now that's among all comers, but if we look specifically within children, we know that immunization has been shown to provide moderate protection against long COVID or PCC symptoms. There was a study in JAMA Network Open in February of 2025 that showed vaccination with an mRNA immunization was associated with a 57% reduction of one or more PCC symptoms, a 73% reduction in likelihood of two or more symptoms, a 72% reduction in respiratory PCC symptoms among children 5 to 17 years old, and a 75% reduced likelihood of PCC symptoms impacting daily function. But even separate from the protective effect of immunization against PCC symptoms or long COVID, we have been seeing declining numbers of individuals diagnosed with PCC symptoms or long COVID as the pandemic has progressed. So, for example, in the pre-Delta variant period, rates of post-COVID conditions, including long COVID, were about 10.5% among unvaccinated individuals. That rate dropped to about 9.5% during the wave of Delta variants, and then dropped to about 7.8% in the Omicron era, but only 3.5% among those who are immunized. Similar to the declining rates of multisystem inflammatory syndrome in children, or MIS-C, we think that this declining rate of PCC symptoms is likely due to viral variants that have emerged, triggering less inflammatory responses and fewer unimmunized or not prior exposed individuals having a protective effect of immunity such that the inflammatory response with new infections is not as robust, and therefore post-infectious symptoms are less pronounced. And in addition to the overall declining rates of those diagnosed with PCC symptoms, we've also learned as the pandemic has progressed that a number of individuals diagnosed with these conditions will experience recovery, though it seems to be over a protracted period of time. For example, in a study in JAMA in October of 2022, authors showed that at the time, about 6.2% of individuals had symptoms of PCC at 3 months following acute infection, but on follow-up at 12 months after illness, symptoms were only present in about 0.9% of those individuals surveyed, suggesting that most impacted individuals will experience a full recovery, though the timeline can be prolonged. And more recent studies have suggested that rates of PCC are lower in children compared to adults, and have also been declining similar to those numbers I cited previously as the pandemic has progressed. And this trend was reflected in a study published in JAMA Peds in early 2025, which evaluated the prevalence of PCC symptoms among children in the United States from 2022 to 2023. Now, the authors demonstrated that of those children surveyed, about 1.4% of them had experienced long COVID or PCC symptoms, but that only 0.4% of them were currently experiencing symptoms at the time of the survey. And I think my takeaway from all this data is that while we are still seeing patients with symptoms of long COVID or PCC, as the pandemic has progressed, those numbers have declined, particularly among immunized individuals, and that data seems to support that while symptoms can be troubling, most individuals will experience full recovery, though it does tend to be over a prolonged period of time. Moving on to question 3, a member asks, practices are seeing more and more pushback from families on infection control policies such as refusing to wear a mask. Are you seeing an increase in this, and what strategies do you use to address those situations? Now, first I will say, because most of my clinical practice occurs within the hospital, we may not see as much of this on an inpatient basis as clinics are seeing this outpatient. However, it has been a problem on the inpatient spaces as well in the last several years. I think we all have trouble with this because we see it as purely a medical intervention, whereas the patients or families who are against these practices tend to see them through the lens of personal freedom. Now, that's a debate I don't want to have and probably wouldn't win with my patients. So I think it's important to focus more on the medical questions about why we are recommending masks within our clinical spaces, in hopes that that can convince families that are against these practices. So why is it we are focusing on all these interventions? Well, it's basically just to prevent the spread of infection within our clinics and between our patients. So again, we are focusing on the health of our patients and families. And while studying infection prevention methods in the real world is messy and difficult, there are studies that do support the efficacy in masking to prevent transmission of respiratory illnesses. And from these studies, we know that the protective effect is greatest when both the source and exposed individual are masked, and particularly when individuals are wearing masks that are well fitted and worn appropriately. And while admittedly masking is not the only intervention that leads to prevention of spread of infection, most public health experts do see masking as a very important component in the overall approach to preventing spread of respiratory viruses. When looking at how effective different types of masks are, studies have demonstrated that N95 masks are best at preventing spread, followed by surgical masks, with simple cloth masks providing the least protective benefit. So we know that masks work and are important at preventing spread of infection, but how then do we convince those patients or family members who are still hesitant? Interventions that have been looked at most often include tailored education to patients and families, repeated engagement on these topics with subsequent visits, and clear, consistent messaging about when and why masks and other public health intervention approaches are necessary. And in your clinic space, it's important to model good behavior with all physician and medical staff adhering to the policies that you would expect your patients and families to follow when they're in clinic with you. So if you have another provider, nurse, or MA who is wandering around clinic with a mask around their chin, it's important that you talk with them and specify why modeling for our patients is so crucial. Additionally, when you're considering creating new policies in the clinic, it would be important to involve stakeholders such as patient families when developing those policies so that you can anticipate what education or messaging is needed to get full buy-in from your patient cohort. And then when it's respiratory season, I think it's important that you stick to your principles. We know that these approaches are important to protect our patients, including those who are most vulnerable to infection, such as immunocompromised patients who can't be immunized. So when you have someone who is pushing back or complaining about these policies, it's important to focus again on why we do them, and that's to protect our most vulnerable patients. And that's it for all the questions this week on ID Talk, but I wanted to finish the episode with just a quick thought. Last week was the second meeting of the Zombie ACIP as it has been established under RFK's leadership of HHS. And I'd just like to put out there to the listeners that after 2 meetings, I think it's safe to say that we as clinicians should not be listening to the guidance of either ACIP or any of the other leadership currently at HHS. Now, I hate to have to say that, and I do want to highlight that there are still phenomenal clinicians and incredible scientists who are working at the CDC, but unfortunately, the leadership is twisting science and data to fit their predetermined assumptions. Thankfully, there are still phenomenal experts when it comes to immunization at the National AAP who are continuing to put out independent guidance on immunization. And I think that for the time being, that is the best source of information on immunizations. with other great resources such as the Immunization Action Coalition or the Vaccine Education Center run by Dr. Paul Offit at the Children's Hospital of Philadelphia. And of course, when in doubt, Dr. Price and I are always here to answer questions from members. And on that note, thank you again for listening. Remember, AZAAP members can submit questions for future episodes to id@azaap.org. The AZAAP would like to acknowledge the generous support of the podcast by the Arizona Department of Health Services through the Title V Maternal and Child Health Services Block Grant funding. For more information and resources related to infectious disease and immunizations in Arizona, or to become a member, visit azaap.org. As always, thank you for these interesting consults, and we'll see you next time on ID Talk.